Hey everyone, welcome back to another edition of 10-Minute Med School. Today we're going to be talking about emphysema. This will be part one of a two-part series where we go over centroacinar emphysema in this part, and then in the next part we're going to cover pan-acinar emphysema. Two different types, they cause slightly different symptoms, definitely two different causes. So today we're going to start with centroacinar emphysema, okay? So before we get into what causes it, let's talk about what part of the lungs is actually affected. So let's draw our model of the lungs. Okay. And in both types of our emphysema that we're going to cover, it's the alveoli that are actually affected. So we can draw our trachea coming down, splitting into our bronchi. These get split into our bronchioles. Okay. Once we get down into like the periphery of the lung, then we get into our alveoli. Okay, so we're going to draw our alveoli structure. It should come out and it should almost look like a cloud. Like we have all this surface area, this nice surface area for oxygen diffusion, for getting rid of CO2. Okay, so see how these alveoli are nice and mature, nice and developed, versus in a centroacinar emphysema, we're actually going to get destruction of the alveoli, okay? So what is that going to look like? That's going to look like that we're going to have this decreased surface area, okay? So instead of our nice cloud-like structure, lots of surface area, it's all going to be eaten up and just kind of look like a big circle, okay? But it's actually not all of the alveoli that are going to be affected, okay? The alveoli that are affected in a centroacinar are actually the more proximal ones. So once we get really distal in the lung, we're still going to have our nice alveolar shape. But once we keep going more proximal, that's where we're going to get those big like blobs of alveoli, okay? So this is going to be our centroacinar emphysema. And this is destruction of the more proximal alveoli. So I'll say destruction of alveoli. Because it's a destruction of alveoli, the actual functional unit of the lung, one of the first presenting symptoms or signs of a emphysema is actually going to be hypoxemia. Let's go into our signs and symptoms of the patient that walks through our door or the person in our test question. So we're going to see hypoxemia. Because we're not able to diffuse oxygen into our blood, we're going to become hypoxic. Okay, the next thing that we might see is we get air trapping in emphysema, okay? So air gets into these pockets, I'll put O2, and just kind of hangs out, right? Because there's like, it's just this big open area, air can get trapped, okay? So we get what's called air trapping. And this shows up a few different ways on a physical exam or on some different tests. The first way that we're going to see it, or the first way they might describe it, is increased AP diameter, increased anterior-posterior diameter, okay? This means that the person like has a really big chest. So if we were to look at someone from the side, like look at them sideways, they have an increased chest width this way, okay? That's from air trapping, so the air is actually expanding their chest. The next way that we might see it on a test is on chest x-ray. We might see increased lucency. So because air appears black on chest x-ray, we're going to see more of that. It's going to appear more lucent. The third way that air trapping might appear on a chest x-ray or on a physical exam is diaphragm flattening. So the air pressure actually pushes down on our diaphragm and can cause a flattening of the diaphragm, okay? Who is this patient that's going to have this centroacinar emphysema, okay? What causes it? Okay, so it's going to be a smoker, okay? And it's going to be an older smoker who's been smoking like a long time, like greater than 30 years of smoking. So that means it's going to be an older patient. So we're probably going to want to see them like over 60 years old, okay? They're coming in hypoxic, they're coming in air trapping. If we were to do PFTs on this patient, so if we did pulmonary function testing on this patient, we're going to see the classic obstructive pattern. Okay, so what is that? We're going to see increased residual volume. That's from our air trapping. Also from our air trapping is increased total lung capacity. Let me rewrite that. total lung capacity. And then the one that they like to test the most, we have a decreased FEV1 to FVC ratio. You want to see that like less than 70%, okay? If they were to just describe it in words. So it's a smoker. He's older, been smoking a long time. If we did PFTs, they're going to show an obstructive pattern, okay? So that's all consistent with a centroacinar emphysema. Okay, so we get destruction of the more proximal alveoli. So if we see this and we can diagnose this, then how would we treat it? So we could treat, the first thing you want to tell your patient to do is to stop smoking, okay? Stop the direct lung injury. And because that's what's causing it, is the smoke actually damaging our alveoli, corticosteroids don't really have much of an effect because it's not so much inflammation. So we're actually going to do inhaled bronchodilators. Something else that I want to touch on is we see emphysema in conjunction with another disease, chronic bronchitis. When we have both of those, when we have emphysema plus chronic bronchitis, we get what's called COPD, okay, chronic obstructive pulmonary disorder or disease. So when we have centroacinar emphysema from smoking, then we get actually like inflammation of our bronchi, which leads to a lot of mucus production. We get what's called COPD. Okay? So that was centroacinar emphysema. Remember, this is part 1 of 2 parts, where in the next part we'll cover pan-acinar emphysema, what causes it, what kind of patient population to look for, and then of course, how to treat it.